last session, our global session of 3 talks in the day. I know people have been with us all morning, so thank you for staying. I continue to learn and get inspired with each of these talks. And I am both excited and delighted to be able to introduce Dr. Cassandra Pierre, who is going to speak about the ghost in the machine, health disparities, and COVID-19 treatment. Dr. Pierre is an assistant professor at the Boston University School of Medicine. She also serves as chair of diversity and inclusion as a part of the Office of Equity, Vitality, and Inclusion, as well as the medical director of public health programs and acting hospital epidemiologist at Boston Medical Center. Dr. Pierre's focus is on population and public health in communities struggling with racial, economic, and social marginalization. Her research is focused on infection prevention in vulnerable populations, and her clinical interests include HIV management in special populations, including immigrants of color and pregnant women. During the COVID-19 pandemic, Dr. Pierre has led Boston Medical Center's multidisciplinary infection prevention and PPE response, designed ambulatory and operative reopening protocols, and advised occupational health and departmental leadership about COVID-19 prevention. She also has collaborated with local community organizations to develop and implement strategies to reduce COVID-19 in communities of color. Dr. Pierre.
Hey, good afternoon. Thanks, Megan. I am going to share these. Hopefully it won't take forever. Okay, great, thanks. So I'm really honored to be invited to speak. I'm excited to have heard from and learned from all the speakers that have gone before me. I am going to be talking to you today about health disparities, really racial disparities, and COVID-19 treatment. You know, as people in medicine and research, we are very comfortable thinking about things that we cannot see, pathogens and pathophysiologic processes that we can intuit, that we can see an imprint for in ways that people outside of our roles may not be able to. But as we've been hearing all through the course of the day, that are things that are outside of our perception that we may not feel comfortable discussing, that have an outsized effect on our patient and participant outcomes, disease detection, and prevention in ways that we are just beginning to perceive. And the weight of systemic racism on COVID-19 infections, hospitalizations, and death in communities of color has been really striking, shocking even though at the same time it was completely expected. And yet we continue to see these same forces causing the same disparities in almost all areas of the pandemic as time goes on. So I think it's helpful to talk about a little bit about these racial disparities in COVID-19 outcomes. Some of these have already been gone over, so I will make it quick. And then really focusing on the causes behind the causes. Much has been talked about in terms of racial disparities in COVID-19 outcomes, of course, and then vaccine rollouts. We haven't really talked as much about treatment and healthcare access, which are just as important. So we'll talk about these and then look at intentional changes. So as promised, a bit of a review. We know that we have, really back all the way back in April of last year, we were already beginning to see the outline, the shape of disproportionate outcomes in communities of color due to COVID-19. And those gaps have only become more pronounced over time, unfortunately. So for Black, Latinx, Hispanic, and Indigenous populations, there are almost 3 times the amount of infections than in white populations. We have 4 to 5 times the amount of hospitalizations that white communities do, and for Black people, they're twice as likely to die from COVID-19 as white people. To put that in perspective, that's 1 out of 645 Black Americans that have died from COVID-19 since the beginning of the pandemic, compared to 1 out of 1,000 Americans in the general population. Back in June, there was a poll that showed that 1/3 of Black Americans knew someone who had died personally of COVID-19, compared to 13% of the general population, and 9% of white Americans that probably is only more pronounced at this point, given that we've reached that terrible milestone of 500,000 people having died from COVID-19 this week. So this is all not because of chance, not because of bad luck, and not because of genetics. We know, and we've discussed here and in other places, that even though COVID-19 is not the great equalizer as it was initially billed, it also doesn't discriminate. And so there are other factors that are involved here. We've talked about these already, the social determinants of health, including neighborhood, household, and employment characteristics that can explain this disproportionate effect. We know that 80% of health status is attributable to the social and economic conditions that involve where people live, work, spend their time. And yet, it's not enough. We've talked about this, but it's not enough to just know this. Addressing those individual social determinants of health are those boxes that Thea and Elena discussed. Addressing food insecurity or transportation or piecemeal approaches. We know that the cause behind the cause is systemic racism, as we've been discussing. And that's in a variety of flavors. We know that the policies and the norms that have been enshrined in our culture and our society for decades have an outsized effect. For example, in housing discrimination with redlining, which caused and maintained segregation within communities that became higher risk due to higher density housing, less access to healthy food, and higher exposure to environmental toxins that were dumped with impunity. That and chronic stress led to the development of chronic medical conditions. Exclusion from higher paying jobs has led Black and Brown people to have to work in hazardous, essential, but dangerous nonetheless jobs that offer less benefits. And then of course, again, speaking of intentionality, coming from a healthcare system that used to be segregated, there's lack of access to healthcare insurance in communities of color, bias in medical decision making, and low representation of physicians and researchers from underrepresented groups. And as part of that, less participation in clinical research trials and preventive medicine. The other part of that, of course, is the trustworthiness that we've established throughout this morning and afternoon session. As already described, these systems, interlocking systems of oppression and bias, do not end at our hospital doors, at the doors of our research institutions. We know, for example, in the beginning of the pandemic, there were many anecdotal reports of Black and Latinx people who presented with flu-like symptoms and were turned away from COVID-19 testing or hospitalization, partly because their hospitals lacked the resources, and then later died from COVID-19 related complications. It seemed like there was a story about this every other day in the spring. There was an evaluation of billing claims in February, March of last year, or billing claims that were done in February, March of last year, that revealed that Black patients exhibiting COVID-19 symptoms were 6 times less likely to receive testing or treatment in comparison to white patients who exhibited symptoms. So our communities couldn't even get to the door, whether it be for treatment or for enrollment in clinical trials. So obviously that suggests that there is bias, more bias than we have appreciated, that there may be bias in our treatment and admission criteria that needed adjustment back then and may continue to need adjustment, thinking about who is more likely to have a high-risk comorbidity and therefore at higher risk for poor outcomes if they're not tested, treated, or admitted. Is there a way to adjust for the reality that bias may lead to the symptoms of Black people being taken less seriously? And also, we know that the mortality of Black people who are hospitalized with COVID-19 is the same or actually lower than white people. And so that actually signals that there may be a more beneficial effect for hospitalization in individuals with more moderate to high disease with COVID-19 who are Black. I just also wanted to point out a few stories, in particular talking about the impact of discounting the narrative of Black people or the symptoms of Black people with COVID-19, encapsulated in the story about Dr. Susan Moore, an Indiana internist who was diagnosed and hospitalized with COVID-19. We know from her own account posted to her Facebook page that she, as a woman with underlying health conditions, felt like her complaints of severe neck pain when infected with COVID-19 were minimized and dismissed. She was declined narcotics and made to feel like a drug addict, in her own words, until she was able to prove that she had worsening infiltrates on a CAT scan that she requested. Her pleas for remdesivir were declined, and she was discharged before she felt that she was ready. She said in her Facebook post, "This is how Black people die." And it proved to be prophetic because she was readmitted shortly after her discharge to another hospital, and 2 weeks after she posted that video, she died at age 52. And after her death, the healthcare institution of the hospital system which she was admitted at immediately released a statement, defending the content of their medical care, if not the delivery. And they mentioned that they were saddened by her death, but did also mention that she was a complex patient. It's kind of a step away from being called difficult. And say that the nursing staff may have been intimidated by an eligible patient. And again, wave that flag that so many institutions do. Oops, sorry. When sometimes being called to account for claims of mistreatment and bias by stating that they were committed to equity and reducing racial disparities. I always love when that comes out because it puts the onus on the person complaining, because the healthcare system is saying, we are great at taking care of people of color. We are not the issue. It's right in our mission statement. The problem is them. Another instance of bias, medical bias, that was called out by the media last summer, different type of bias, but still pervasive and insidious, occurred at a well-established hospital in New Mexico that had a secret policy that separated newborns from their mothers without consent until the maternal COVID-19 test returned as negative. And we know it was secret because it was not documented in any hospital policy, online, no emails, but it was read aloud at the beginning of every shift, every day for months. So obviously it was important to that hospital. And here, only Native American women, especially those who resided in zip codes that were associated with reservations, were subject to that additional screening and separation, which is pretty bold, knowing about the history of child separations in cultures such as the Navajo that were predominantly targeted here. A federal investigation, unsurprisingly, found that this was medical racial profiling, and that the hospital had violated the rights of patients by separating mothers from their newborns. Interestingly, the hospital contended that they did nothing wrong, although they did stop the policy. So again, you have these institutions that are somewhat blind to the impact of systemic racism, even within their own facilities. And there's so many instances of this throughout the course of the pandemic. I won't go through them. What I will say is that, unfortunately, when we think about what really matters to us, which is who gets treatment, who gets access to treatment that is potentially life-saving, we don't have enough data to say that at this point. We don't know. And so a lot more work here is needed, including looking at access by race and ethnicity. But there's a justifiable concern that there's a disparate level of funding in hospitals that predominantly care for Black and Brown communities. That will lead to less access to appropriate treatment and protective equipment for healthcare workers. We know that the initial federal COVID-19 relief funding is based on revenue, and so smaller community-based hospitals with larger numbers of Black and Brown patients received lower funding to manage a greater COVID-19 burden, which means less funding for testing, less funding for protective equipment. And in addition, these same hospitals and healthcare systems in structurally vulnerable areas have traditionally have had less access to participating in clinical trials, which here is not just an issue about representation or ensuring that treatment works, similarly across different demographic populations, which is definitely very, very important. But in this setting of a pandemic, this is actually about survival and life and death in terms of having access to experimental treatment. So with remdesivir, I think, I won't belabor this because CTSI had a multi-institution discussion about access to clinical trials across race and ethnicity several months ago. But as a reminder, this is the first drug that was found to have a beneficial effect on hospitalized patients with COVID-19. And although, again, Black and Brown communities are overrepresented in terms of those who are hospitalized and die, they were substantially underrepresented in the clinical trials of remdesivir. So 18% of over 1,000 individuals in the two of the three large RCTs that established the efficacy of remdesivir in hospitalized populations were Black. And that's compared to 44% of all hospitalized patients in the United States who are Black. So as a result, Black, Latinx, and American Indian patients were less likely to have access to and to receive remdesivir. We see similar disparities in monoclonal antibodies as well. This is the only approved outpatient treatment for COVID-19, recently received an emergency use authorization in November. It's intended for use in individuals who have mild to moderate symptoms but are at high risk to progressing to severe disease. This has had a more ambivalent rollout because the benefits are modest and the studies are still ongoing as to the effects of monoclonal antibody. And yet, even with that, the effect of disparities in rollout and administration to communities of color, based on the information that we have now, is quite striking. Part of the reason, and I'll get into what those numbers look like, part of the reasons of the factors that impede allocation are also much more pronounced potentially in hospitals that serve communities of color, in hospitals that serve under-resourced and structurally marginalized communities in general. There's limited space and staff to administer these infusions in hospitals that are already contending with surges from COVID-19 within patients. Infection prevention concerns are significant. You're trying to keep actively infected individuals who can take care of themselves at home out of the hospital and off of public transportation as much as possible. So how do you get them in a safe manner? Many hospitals have declined monoclonal antibody allocations from the government. And although I don't have data to tell you that it's more, this is more likely to be declined in areas where there's disproportionate amount of people of color being served, we do know that in our state, it does seem like a lot of the safety net and essential hospitals outside of our own are not carrying monoclonal antibodies. And of course, always the trust gap in patients who are understandably concerned about an under-researched treatment being offered to them. So in Massachusetts, 20% of monoclonal antibodies were intentionally and explicitly reserved for individuals in structurally vulnerable areas that include more people of color. So there was this intent to go in and say, okay, we're going to allocate, we're going to hold these reserves for people of color. But despite that intention, what we still see is that the DBH reports that the vast majority of recipients of monoclonal antibodies, 83%, were white, 6% were Black, and 6% were Hispanic and Latinx. And so beyond the factors that I just mentioned that would impede distribution of the monoclonal antibody to communities of color, there is an unseen hand. There is something else here preventing access. And that something might be bias in treatment guidance, including for those in ambulatory patients. There are many other things to pick, but there are some things that we have not yet put our finger on. So, as I mentioned previously, the same factors that were at work in the spring are at work now in the winter in terms of the disproportionate effects of COVID-19 in communities of color. And our gaps are widening, and they may widen even further, unfortunately, with the concerns of disparate uptake of vaccines in communities of color. So we need to acknowledge, first of all, and we need to confront this, that systemic racism in medicine and research has had negative consequences in Black and Brown communities, and that we ourselves are culpable for that. We need to initiate reconciliation with structurally vulnerable populations to build those bridges and rebuild trust. And as people have said previously, even though there's this urgency, especially for COVID-19, although a lot of the things that we discussed are equally applicable to other infections and disease processes, we need to focus on the process as well as the outcome to build that trust. Self-reflection and understanding how bias operates in our own system and our institutions and on an individual level to perpetuate racial biases is imperative. So thinking about the algorithms, for example, for treatment and for admission and how those might be affected and changed by populations who are disproportionately affected, not just by this pandemic, but by lack of access to social determinants of health is incredibly important. We always need to monitor those outcomes on a regular basis. Focusing on impact and systems change and engaging those who are most impacted with community engagement, not just when the research has already been developed, but at the very beginning of the process to identify what are the outcomes of interest that are meaningful, not just for the research community, but for communities that are going to be more heavily impacted is critical. Workforce development is something that will be discussed in the next session, but focusing on recruitment and retention of URG physicians, healthcare workers, and research assistants and research staff is necessary to build that trust and to ensure patients get the best outcomes by engaging in preventive health as well. And clinical trials must prioritize the inclusion of patient populations that reflect the demographics, in this case, of the ongoing pandemic. I'd love to thank you for your time and welcome any questions you may have.
Thank you so much, Dr. Pierre. Incredibly sobering, but I think really important to have these data and to be very clear about the inequities in diagnosis and treatment and some of the factors that have contributed. So I'm going to look to the chat box to see if are any quick questions. We remain a little bit over time, so our catching up just a little bit. So what I may ask, if it's okay, Dr. Pierre, as you see questions pop up as we move to the next talk, there have been, I think, some really good dialogues back and forth, I think both between people in private chats and also publicly about all of the lectures, I think, as people think and put in questions. But I think incredibly important, and it starts to, I think, bring forward the need for a systematic and systemic response that continues and takes some of the lessons we've learned from COVID and into all of our other work as we think about health and healthcare and research. So we are going to move on to our next talk, which is the Black Women's Health Study, 25 Years and Counting, by Dr. Kozier. Dr. Kozier is an associate professor of epidemiology and the assistant dean of diversity and inclusion at the Boston University School of Public Health, and a senior epidemiologist at the Sloan Epidemiology Center at the Boston University School of Medicine. Her research is focused on the influence of psychosocial factors, including experiences of racism and neighborhood segregation in the development of chronic illness and women of color. Dr. Kozier is a longtime investigator on the Black Women's Health Study and is the co-principal investigator of the EPI-AWARE study of Asian American women, a collaboration between the Schools of Public Health and Social Work. Thank you.
Thank you so much for having me. I'm going to talk to you about the Black Women's Health Study, which has, of course, been going. We're now entering into our 26th year. 2020 was our anniversary year. I first want to introduce members of the research team. The study is led by Drs. Lynn Rosenberg and Julie Palmer here at the Sloan Epidemiology Center, and co-principal investigator Lucille Adams Campbell at the Georgetown University Lombardi Cancer Center. And my colleagues at both institutions are noted below. So I began with this study as a doctoral student back in 1995. So I literally came in with the first questionnaires. And at the time, there was this editorial cartoon in the Globe and other newspapers asking, trying to address the dearth of understanding and knowledge regarding Black women's health. And I've used this comic ever since. I've tried to retire it, but it does not lose its its relevance. So I continue to show it every time I present. And basically, our healthcare system is focused largely on the majority and has traditionally been focused mostly on male health. So Black women's health has not been addressed. And the Black Women's Health Study began in order to help fill that void, to help understand why it is that Black women have 2 to 3 times at minimum the risk of disease for almost every major condition compared to white women. Again, we can't address that besides simply trying to put it into a black box and say maybe it's a mystery gene or some other biological thing, but we can't address any of that until we start to study women in a systematic way. So based on the format of other large cohort studies, such as the Nurses' Health Study, the Black Women's Health Study began and sought to prospectively assemble and follow a cohort of women. The source of the study was mostly members or subscribers to Essence magazine. And for those who are not familiar with Essence magazine, Essence and other magazines like it are staples traditional staples in Black households. Throughout my lifetime, my mother's lifetime, and so on, it was Essence, Ebony, or Jet magazine that came to the household and kept the community, the diasporic community, up to date on all things. So this was a source in which we would capture individuals from all 50 states, also women who were literate so that they could complete self-report or self-completing questionnaires on medical conditions, and that we could follow. So from that baseline cohort, we enrolled 59,000 women between the ages of 21 and 69, and we have been updating them every 2 years since. So at the bottom, you can see the timeline, and we're literally sunsetting the 2019 two-year questionnaire cycle, and we are about to begin the 21 through 23 questionnaire cycle. Participants in 1995 had a median age of 38. About 80% had education beyond high school, and they represented all regions of the United States. As I mentioned, every 2 years, we issue a questionnaire that covers body size, reproductive history, lifestyle factors, including diet and exercise, medical history of both the participant and often family history, use of medication, and numerous psychosocial factors, one of which I have studied quite a bit, being the psychosocial stress of perceived racism. Oops, sorry. So we have, over the years, linked our data to cancer registries, to confirm our cancer diagnoses, to Medicare, to confirm other diagnoses, to get more information, National Death Index for mortality. The Census Bureau has been used to characterize residential neighborhood, and also through the Census ID, facilitate linkage to the Environmental Protection Agency and Sentinel monitoring sites, so that we could also estimate exposure to pollutants from the residential standpoint for participants. We've also created a biorepository over the years. We began in the early 2000s collecting buccal DNA samples from participants, and have that on approximately half of the cohort. In the last 10 years or so, we've gone after blood samples in the cohort using Quest Diagnostics infrastructure throughout the United States. For various cancers, particularly and primarily breast cancer, we have collected tissue blocks and slides, and my colleague Ken Bertrand has, in a breast density study, has collected digital mammograms. We stay in touch with our participants in the community and in general by frequent communication. We publish a newsletter for participants twice a year, keeping them up to date on the status of the research. We have a Facebook page. We have a participant, advisory group. These are women who are part of the BWHS who can work with us to, maybe we could field questions with them. Would this be an appropriate question? What would your response be to this question? How can we temper this question? And they give us a lot of valuable feedback as we go into different areas. We also engage with community organizations that work to foster and promote Black women's health. So over the years, our 25 years, now going to 26 years, we've published nearly 300 articles. You can find a full listing of our publications at our website, which is given here. The study was funded and is funded primarily through the National Cancer Institute. So there's a great emphasis on breast cancer and other cancer types. But even as in a cohort study, there are many other conditions that arise and that can be captured pretty rapidly. So we have published on a number of non-cancer conditions. We've also have been analyzing cardiovascular disease, and as our participants age, we are moving into other outcomes, including cognitive health. There's just a couple of very quick examples of some of our publications. We published this back in 2011, looking at general and abdominal obesity in relation to mortality. And at the time, there had been some inconsistent results in the literature regarding overweight and obesity and the risk of mortality. And in particular, many studies, large studies, included few Blacks. So also a few studies reported separately on Blacks. And in terms of abdominal obesity, sometimes those measures weren't included at all. So what we were able to do was explore this within our large cohort. We had many years of follow-up. We were able to do some lagged analysis so that you were not looking at the BMI at the time of death, but perhaps, being able to look prospectively. And we did find that mortality increased with increasing levels of body mass index, but we were also able to look separately at abdominal obesity and find a similar association. Here's another important paper looking at breast cancer prediction models. So one of the main prediction models, the Gale model, underperformed on African American women who are tended to be younger when they have their first, episode of breast cancer or when they first diagnosed, and this was not captured in that model. Also, there was little differentiation according to molecular subtypes. There was an update from the Gale model that was expanded to include African American women. However, that model we found, again, under predicted women who had estrogen negative breast cancer. And also we found that by including other factors such as age at first birth, that the model was improved. And that was because of the age of first birth of the age within our cohort would have been missed within the typical model. So Dr. Palmer is currently working on developing an improved risk prediction model that considers particularly breast cancer subtypes. And this will be very important because it's these risk prediction models that also determines eligibility for clinical trials, certainly. And if the factors that are being applied to Black women are missing many of their risks, it's one of those other things that is contributing to low participation in clinical trials, among other things. More recently, we have looked at experiences of racism and its effect on subjective cognitive function. So as I mentioned, our participants are aging, and we were able to use a dementia assessment tool, not through the telephone, but actually on questionnaire data. We use elements of that. And we have been collecting information on experiences of daily and institutional racism in 1997 and again in 2009. And we found that the women who reported the highest levels of daily or institutional racism had nearly 3 times the risk of poor cognitive function compared to those women who reported lower levels. So as women age, the cumulative effect of racism has an important effect on their overall health, including their cognitive function. We're moving into a few new research areas. So again, as the cohort ages, Alzheimer's disease, and at the bottom, COVID-19. So I just want to very briefly talk about a few of these areas. We've also found insomnia to be something that increases with age. So through outside funding through PCORI, we're conducting a nested randomized control trial to study some web-based therapeutic approaches, such as the shut-eye, in combating insomnia in Black women. We were recently, well, actually not recently, but almost a year ago, funded by the American Heart Association to explore the impact of COVID-19, but through first documenting the experiences that Black women have had, accessibility to testing, looking at the severity of their disease, their risk of infection, such as household configuration. Also, it gives us an opportunity to look at vaccine hesitancy, but importantly, because this is an American Heart Association funded illness, looking at cardiovascular complications of COVID-19. And finally, as we continue with COVID health, we are working on a pilot to determine whether a smartphone-based technology can be effectively applied within this population to again, track cognitive health. So as I've said, we are 25 years young of this study. So we, to celebrate with our participants, we had in the pre-COVID time, hoped that we would have a 1 or 2 day symposium and have something where we could invite local participants at least, and then perhaps, live stream to those who couldn't attend. Once the pandemic set in and it was clear that we were always going to be on Zoom, at least for the duration, we switched to having a webinar series. So last September and November, we had 2 webinars. One, the first was really an overview of the Black Women's Health Study with many of the investigators and advisory board members. So we went through the history of the study and interacted with participants. And then a second one was on COVID-19, where we did pretty much the same thing. We're planning others, at least one more for later this spring. So we'll keep you tuned in. You can go to our website and look up information. But just to conclude, the Black Women's Health Study hopes to continue to provide valuable data for understanding the illnesses in Black women. Clearly, disparities are persisting and there is much to learn, but our model and what we have so far contributed is addressing, traditional risk factors, those psychosocial risk factors such as perceived stress, perceived racism, even neighborhood socioeconomic status as a source of stress or resilience, and also genetic components. And we hope that from this knowledge that this will lead to more effective prevention programs and certainly narrowing the disparities gap. So again, this is our website. I invite you to visit us. You can see our past webinars, and you can also find a full list of our publications. So thank you very much, and I'm happy to take any questions.
Thank you so much for leading such an important longitudinal cohort study. I think we have time for one question, so I'm just looking at the first question, which is actually from our next speaker, so a good transition. Tell us about mental health outcomes that are part of the Black Women's Health Study.
Sure. So what we have, the questions that we have asked traditionally are screens for depression, so the the CESD, the CESD instrument. We've also asked within our health conditions whether women have been diagnosed with depression and are being treated with medication. And we are able to also capture reported medications that would have the specific indication for anxiety or depression.
Great, thank you so much. And we are now turning to our last talk of the day by Dr. Henderson on workforce development. And I think that this is an incredibly important topic and one that other people have referenced. I know Dr. Pierre talked, for example, about in her future steps, thinking about the pipeline and having a diverse health workforce. So Dr. Henderson currently serves as psychiatrist in chief at Boston Medical Center and professor and chair of the Department of Psychiatry at Boston University School of Medicine. He previously served as the director of the Chester M. Pierce Division of Global Psychiatry at Massachusetts General Hospital, and was the director of the MGH Schizophrenia Clinical and Research Program, as well as being medical director of the Harvard Program in Refugee Trauma. Dr. Henderson serves as co-director of an NIMH T32 on global mental health clinical research. He has worked internationally for 21 years in resource-limited settings, as well as areas impacted by mass violence, disasters, and complex emergencies. He has a long career in research and all types of research, including clinical trials. And so I think it'll be great to hear his perspective on workforce development. Dr. Henderson.
Great, thank you very much. It's been a wonderful day, incredible speakers, and I'm really proud to be a part of this. I'm going to go through some specific topics around workforce development and perhaps give a little bit of examples of what we've been able to do in our department if time permits. But as you know, we still have a problem in medical schools where the faculty are predominantly white. Diversity among medical student applicants has increased significantly, but this hasn't caught up to the faculty. Most active physicians over the age of 35 are white, 56%, and male, 64%. Only 5% are Black and 5.8% are Hispanic Latinx. So we have these huge gaps. And as we think about it, I think there are tremendous efforts to recruit into medical school a more diverse group of people. And I think there's a drop off when it comes to recruiting faculty from diverse backgrounds, and then even going into residency, there's also considerable efforts to recruit residents, but the fact that can we retain them, and I'll talk a little bit about that. So it's important to look at the only 4% of full-time faculty in medical schools or in academic medicine are Black or African American, Hispanic, or Latinx. 39% are women. Though that there has been some progress in the gender, but there continues to be a great need for more progress. And of course, we've heard today, the benefits of having a diverse group of faculty, clinicians, researchers. First, it fosters scientific innovation, it improves quality of research, increases the likelihood that research outcomes will benefit individuals from underserved or health disparity populations. And people have touched upon this. Some of the challenges that many researchers have faced is to how do you connect with populations you want to do research with and help, and then we have to look at the diversity within the research, not just even the PI, but the whole research team. There are opportunities to improve that across our hospital and schools and so on, as we attempt to gauge different communities. This may increase participation of health disparity populations in clinical trials, and certainly, the issue of public trust has come up quite a bit. So, having a diverse group of investigators really is one part of improving public trust when you're working with communities of color. And then it enhances global competitiveness, and that really is actually quite true. And I think that having a diverse group of investigators, really, along with our very diverse population, and many of the things that one would want to study often have not been, studied in our population, but that would lead us to be in a really strong position to be very competitive for grants and so on. And I think this is one thing that we have observed in our department once we got our act together and improved our investigators and diversity and so on. We've been much more successful at obtaining grants. Now, I think the data shows that from NIH, the large percentage of grants are awarded to white individuals. And NIH credits, they've had probably more than a decade or more, push to really diversify the investigators. And so if you look at the pie chart from 2010 to 2016, you can see there has been some progress, but and I think that I just saw some 2020 data at a meeting, and that progress continues. So there has been some efforts, and I think NIH has a pretty extensive plan around diversity, and I think that they have shown that there has been some progress. There's still a long way to go, but progress actually can be made. But I do want to point out that just recruiting people is only part of it. And so when in my experience, when I was at Mass General, we had a huge effort to recruit individuals into our residency programs, and we were quite successful. But what we were not successful at is at retaining them. So we were training these, really incredible people, and they all would leave. And so, but if here's a statement from a medical student. Although I don't speak for all Black medical students, I know my experience is not unique. We have suffered comments made about our appearances, for example, and have had security guards question our presence on campus. We carry these and other disturbing experiences with us to class as we study our pathology notes and worry about our next board exams. In addition, we bear the news of the extrajudicial killings of Black people and learn about health disparities that are robbing our communities of life. The stress of all of it can be crushing. And so if you can see that, like, there's a whole bunch of stuff going on here. And so getting people in the door doesn't necessarily mean, number one, that they're going to have a good experience, and that's on our institutions. And number two, they may or may not stay for various reasons. So we have to be mindful that it's not just recruitment, it's the retention. And I think where there are often gaps, it's around the retention component of this. We are in a great city of Boston, where there's in region where there's so many schools and just fantastic schools and producing really unbelievable talented young people, and so we actually should be benefiting from that, but there are things that we have to address. So in mentoring Black, Indigenous, and people of color students, they're less likely to be mentored than our white students. And I certainly encountered this at Mass General, and I've encountered this here as well. We've worked very hard in our department to address that. Faculty members are key for BPOC's success, especially in those fields where they are underrepresented. Positive mentorship improves research, productivity, academic promotion, faculty retention, career satisfaction, and enhances biomedical research, patient care education, and faculty diversity and leadership. 93% of residents interested in pursuing academic medicine reported that mentorship positively influenced their ability and decision to pursue a career in this domain. However, only 70% believed that they had adequate mentorship along the way. Residents also reported that a gender, race, ethnicity match was encouraging and added value to mentor-mentee relationship. And of course, it doesn't necessarily always have to be that way. But on the other hand, it actually does help. And, you know, I encourage people to have multiple mentors. You can have a content or expert mentor for your area, but you need a career mentor, and you certainly need somebody who looks like you or may have had similar experiences that you're going through. And that's actually really, really important. And biases create exclusionary practices. We've heard this today. And although pipeline programs, mentorship, and other factors can improve an individual's readiness for medicine, widespread implicit and explicit bias create exclusionary environments. And that's what I was alluding to. It's like we can develop a lot of programs, and I'll talk about some in a minute, but it may not be enough to counteract all of the negative experiences that BPOC students, physicians, clinicians, faculty may experience. And so we have to think about, like, are we doing enough with the programs that we have in order to overcompensate for this, but also, as others have pointed out, are we changing our environment so this type of stuff just stops? So there is equity, and people go about their business, and their stress comes with, they're doing their research, not how their interactions with others and how they're perceived by others and so on. So we really have to get there from a research standpoint as well. Now one a model that has come out of some residents at Yale, they tied recruitment with community engagement, mentorship, and social network. And I think that's really important. And particularly the social network piece is, I think, often left out when we recruit someone new. And we may say, okay, we're going to give you a mentor or a buddy or that sort of stuff. You did one person, but what we should be doing is connecting them to a whole network of people, and so that they have a place to go to ask questions, to hear about others' experiences and so on, and to problem solve when they encounter issues or conflicts and so on. And that was, like, striking to me at Mass General, in that that social network piece was completely gone. In fact, it was replaced by total isolation. And so I encountered people who had been out of the department for 5 years and I had never met or heard of, and they were just isolated in their own little research group, and not connected, and they were disengaged with the institution and eventually left. It was a story that we heard over and over again. So that social network component is actually really important. And so this is just definitions of what this house staff put together, but monthly general gatherings, there's a whole bunch of things that can be done in order to help, and to help people be comfortable in their environment, which is, I think, again, really clear. And of course, there are a lot of, pipeline programs, and this has really come from NIH. And I think that we're fortunate that we have probably all of these all of these pipeline programs at our collective institutions, pre-college, college, pre-doc, postdoc, career and research. You know, the CTSI has incredible programs. So we have them all, but you know, one thing that it's not clear to me if these programs are connected, and you know, meaning that like in my global work, when we work to capacity build, we talk about being mentored or being pulled up by someone who's ahead of you, but also while you're pulling somebody up with you. And so it would be really cool to have, and to start, each of these groups, learning how to mentor while they're being mentored. But, but it would also expanding that network, connecting them to others that are already achieved what they want to achieve, and make that a kind of a sustainable relationship. And so there may be some opportunities for us to do a bit more along those lines. And of course, I think BUMC, have, really expanded its faculty development programs. And I think it's fantastic. And we need to encourage as many people as possible to participate. But again, I think that, what they learn from those programs needs to come back to the departments and to their chairs and to their mentors and so on, so that so there really is a kind of a long-term mentoring and career development process, not just fulfilled by taking a seminar for 6 months or 9 months and so on. So we really have to continue to work on that. And so I think that, there's a bunch of things that one can do. And I think that we've heard a lot about the eagerness for us to change what we do and to change our environment, to really be able to recruit a diverse group of faculty and staff that represents our patient population, to nurture them, to give them opportunities for growth and development and leadership, which I think is really important. And then to, of course, the overall goal is to retain talented people. And so in our department, we had struggled with diversity and retaining of our own trainees, and we had to go through a whole series of processes in order to first make our department a place where people would want to stay and work. So we had to fix the clinical aspect of their job. We had to create research opportunities and education training opportunities, and which had not really existed before in the department. And then we, once we started to recruit people and people wanted to stay, we were able to recruit a much more diverse faculty. For instance, I think I would probably say in the last 2 or 3 years, 50% of our faculty hires have been, at least 50% have been non-white. Majority have been women, but that's typical for our profession at this stage. But at least 50% have been non-white, and even in the next 5 months, we have, I think, 3 African American women starting in the department, and they're coming from other institutions now, from across the country. And so I think that, and the big thing that they say to us is, well, your faculty is so diverse, this really was attractive to me. And so once you get to a threshold, I think that it does become easier to recruit. But again, we just have to spend a lot of time focusing on retention creating opportunities, providing the mentorship, but also creating the environment where people enjoy working, they feel safe and comfortable, and they can focus on their work and not be bombarded with these microaggressions and so on. And I think that we're definitely moving in the right direction. So I'll stop here and see if we have a minute for questions or so. Thank you.
Yeah, thank you so much. And we are reaching the end of the day, but I see a question that just popped up, which is what specific measures did your department take to recruit more diverse faculty?
Well, well, that's a great question. There's no quota, there's no number that we look for. We just made sure that our searches were broad enough that it reached individuals of color, and we chose the best candidates. But if you have excuse me, if you have a lot of candidates of color in your pool, like there's a lot of good ones, it turns out. I mean, we had to turn some people away. So I don't think that we went about this in a scientific way. We went about this in a, this is the right thing to do. But we made sure that our searches were broad enough, and we networked and reached out to people and so on. And then now, mostly they come to us. So you know, once we, I think, hit a kind of a threshold, it became that people are seeking us out, which was actually very different.
That's great. Thank you. Thank you for the important talk and concluding the day, a day where I have really learned a tremendous amount, and I think we've covered a lot of important topics. So I'm going to turn this back to David and Chris just to finish the day up.
I want to thank everyone, particularly the participants and the audience, for a spectacular program that truly did honor to the memory of David Selvin. I was captivated by the talks all morning, and I learned an enormous amount that will, I think, alter the way in which I look at research and the way I look at how we address social issues and race in the future. So thank you all very, very much. Thank you, Chris, for all the hard work and organizing and getting all these people together to celebrate David Selvin's honor and to give us some insights into race and research. And Chris, any last words?
David, thank you. I thought that today's symposium was really successful. And I think I agree with everything you said, and I'm not going to delay anything else. I'll say one thing, though. I think that we could say that this was an interactive session. It's hard to pull that off in a Zoom setting, and it's hard to pull it off with a group of over 100 people. We pulled it off. I really felt that there was a dialogue that occurred, and the speakers were obviously provocative and got us to really think, and I think our audience, you know, responded and asked really good questions, and we really did achieve some growth as a group. So anyway, thank you all for attending. We'll probably be talking to you again in about a year or so, and
please join us all next Tuesday for the poster session.
Oh, yes.
You'll be able to see our trainees' contributions to translational science and to the topic of today's symposium. They will very much appreciate your input and activity and your interest in the research, and it's the way that we perpetuate our research enterprise, and as Dave Henderson said at the end, the way we retain people to show that we're interested in what they do. So thank you all again.
That'll be in 2 weeks, March 16th.
Excuse me, 2 weeks. Thank you.
thank you all. Have a good day.